You know what needs to change. You know what's wrong. We gotta treat people the same. We gotta get along. Do you know the history of the country where you stand? Do you know how they treated the first people of the land? Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Come back, we can rewrite.
My name's Robyn Aitken and my colleague Dr. Judith Lovell. I'd like to start by acknowledging the privilege to be on Central Arundel land. You know, the weather has just been astounding and we've been really privileged to not only be here these last few days but to do the work that we've been doing over the last while, funded by Carson. I'd also like to acknowledge our community consumer co-researchers who couldn't be here with us today, and Annie Lowell, who's our other research team member who couldn't be here. We decided to just have a chat and a conversation about what we've done, trying to pick out some things that really have changed the way we've thought from what we've learnt from our co-researchers. Cherie, our project's been about trying to measure some of those non-clinical indicators. I've been working in the area of looking at an organisational level improving cultural safety. So not the individual interactions, but how can an organisation provide a much better environment for people, and looking at health organisations. And I have to tell you that the work I've been doing has been using surveys for a long time, as well as interviewing people. But this research has just taught me a lot about throwing that out the window. And we're going to talk a little bit about surveys today. So I'm just going to give you a little bit of an overview, and then Judy's going to really give the guts about what we've learnt from our colleagues. So our background, this is about exploring and improving processes for speakers of Aboriginal language. And our background is that many Aboriginal people who we encounter in health services, English is not their first language and they don't speak English at home. So how on earth do we understand what sort of quality experience people have and how the communication within a health setting has such a profound effect on people's quality and engagement when we're not speaking the same language? So lots has been written about the problem, and you know there is just so much about how problematic it is, but we wanted to actually provide some guidance about how to solve it. So we undertook this project with the Central Australia Health Service, who were in the process of trying to measure patient experience using a national survey tool that had been translated into Aboriginal language, was going to use an iPad to ask people questions. Central Australia Health Service was really worried about this process, and we engaged a process to try and improve that we actually found was problematic in itself. And I'm going to hand over to Judy to talk about that.
Thank you, Robyn. So taking up from where you've put us, the survey to measure quality and people's experience was intended to help consumers of the service inform the service, and then all the way back up into the national data and programs about their experience of safety and treatment at any hospital, at any health service. So the tool that had been developed came to us with 3 languages, 3 different language loops, Pindara, Aranda and Walbri. And the questionnaire was the standard national, I think 10 or 12 question questionnaire. So we had a good research design. Our intention was to engage with knowledgeable Aboriginal speakers, people with lots of experience in translation or interpreting, and people who'd worked in health and so on. And the town's actually really rich with people with that sort of experience. First Nations people who speak strong language and have worked in those fields for years. And so immediately it became really apparent to us that the survey tool and the process of having the tool interpreted was really deeply flawed. And in fact, as soon as we tested the audio, we found that the audios didn't make sense. They didn't, to a language speaker listening to that language audio, that the questions were in some instances the opposite of what the English question had intended to ask. So this tool could have gone out in that state. It could have been rolled out. That data would have been backloaded through the regional jurisdiction and into the federal database, and the territory's decisions about the territory's health service delivery would have been based on at least 2 questions that were flipped completely backwards. So it kind of wasn't a small thing. This is quite significant, and we were alarmed about it. So we went further with our back translations, and the deeper we went, the more that we found people were very reluctant to work on the language and concepts of the survey because they just simply didn't hold meaning. And so while an interpreter could give us the words, the same word in English is said like this in Aranda or in Walbury, when those words were jumbled together the way they would be according to the English words, they were pretty senseless. Really simple or fundamental things, asking someone to tell you their story, it's not a conversational way of engaging with information. So the further we went into it, the more problems that we found with that instrument. And then one of the directions that the work then went in was to actually really focus down on pulling apart some bigger surveys. So, and that would be the work that Annie's been leading.
So we teamed up with a larger study, the Return to Country renal study, to involve more consumers and different tools that they were going to use, and tried to develop a best practice way of working with Aboriginal language speakers to actually develop meaningful tools. And what we found out of that was that the process of going through to develop those meaningful tools actually gave us the richness of information. And that if you were to take the time to do that best practice of speaking to people about what is it we're trying to find out, what does this mean culturally, what does this mean for you in a language sense, in a experience sense, then in fact you didn't need to do a survey at all. If you used that technique as a start to have those conversations that we're now informed about, that you could in fact get much better and richer data. Our problem is, though, health services don't generally have the time to do that or the capability to do that. So we're a little bit stuck in how to go forward with doing that. What we did pull out of that process was that one of the really important things is that whoever in a health service is trying to understand Aboriginal people's experiences, that they actually have that understanding about language and culture in the first place. So we've funded for a phase 2, and our phase 2 we're going to be working with, again, Aboriginal health consumers, co-researchers, to work with health service staff to learn more about them as people rather than them as patients. Because the thing that our co-researchers kept on saying to us was they just keep on thinking about this very narrow part of our life, and we want people to know much more about the full breadth of us before they start asking questions about what was our health experience like. So that's our next step.